Hello, everyone, and welcome to today's webinar, Increasing Nursing Efficiency, Nurse Documentation Simplification. My name is Maria Sigala, and on behalf of all of us here at Chartis Clinical Quality Solutions, thank you so much for joining us today. This is one of our monthly clinical webinars. This is January, Increasing Nursing Efficiency, Documentation Simplification. And for February's topic, Better Meetings, Better Results. And March topic is Meeting Challenges in the Physical Environment, Addressing Common LS and EC Vulnerabilities. Hope you will be able to join. Before we begin, I'll walk through a few quick housekeeping instructions. This presentation is designed to be interactive, so please become part of the discussion by typing questions or comments into the Q&A box you see on your screen. Time permitting, we will also call on participants with raised hands, which is located on the reactions menu. Today's session is being recorded and will be available within a couple of days. The handout for today's presentation will be uploaded to the webinar's chat throughout the session for those who joined us late. You'll be able to access the recording and handout by going to chartisquality.com, clicking on Insights, going to our webinar page, then locating the Increasing Nursing Efficiency Documentation Simplification webinar. Our past webinars are also available on our webinar page. If at any time you don't see the slides moving or you're having trouble with the audio, try refreshing your browser first. You can also submit any technical questions into the Q&A box. We are here to help you at any time. Thank you all so much for being here with us today. I'll now turn the floor over to Bud Pate to begin the presentation.
Thanks so much, Maria, and Happy New Year, everybody. I guess it's already what is today, the 19th, 20th, 19th. So yeah, I'm still getting used to writing 2023 on my slides. I spent a lot of time updating the slides, so welcome and thank you for joining us at the first of the year. It's gonna be great. I just wanted to let you know that the past webinars that are up there, in addition to the ones that Maria was just saying, cover a broad range of the things that we do. Just the practical approaches to survey EMTALA, suicide precautions, responding to CMS findings, how to not to overcommit and underperform, infection prevention, and then just in December we had looking forward to 2023. As Maria said, all of those are available on our website, and then coming up in months ahead, we're going to be looking at meeting management, really getting twice as much done in half the amount of meeting times, half the amount of meetings, overcoming physical environment challenges, addressing point of care performance, and all the and on and on. And we'll have one of these every month. It's what is this, the third Thursday of the month, is where we have it at 1 p.m. Eastern, 10 a.m. Pacific time. I'm going to be joined virtually today by Kim Wilson. She'll be helping out, and she'll be giving you some of that ground level practical advice on simplifying policy and documentation. Before we get going, and Maria, I think you're going to be running the poll, I believe. Is that correct?
Yes, I can do that.
Okay, if you could start the poll, we're going to ask a little bit about you, and this is what kind of organization do you represent? Hospital, psychiatric hospital, health system, other provider, or another consulting group, and we have those kinds of things. And while you're taking the time to enter those things, I'll have Maria post the results in a minute. Tell you just a little bit about Chartis. We do a lot of different things. We're now called Chartis Clinical Quality Solutions, but for decades we were known as the Greeley Company. And so we really specialize in high reliability care solutions of all kinds. We have medical staff bylaws and organizational work. And we have interim staffing and education solutions. So we covered the gamut. It looks like most of us are here from as you can see here, the results of the poll. Most of us here are here from hospitals and a couple from health systems. So thank you for joining. The objectives today, we're going to understand how to avoid complicating your life and the life of the bedside nurse or caregiver, and inject a little common sense in policy process and reduce duplication and connect policy and practice, all those good things, and streamline and simplify nursing documentation. And like Maria said, the program slides are in the Chartis chat. One more poll before we get into the meat here. What is your role? Are you quality and safety, regulatory compliance, nursing leadership, nursing education, clinical informatics, or other? And if so, if you could just answer that here as I go through the next couple slides, and then I'll ask Maria to publish it, but don't publish it yet. So here's our agenda. Less is more. And then we're going to go on to the current situation briefly. And then the practical tips will be a virtual presentation that Kim had recorded prior to today because she actually had to be on site with a client in trouble. We spend most of our time in the field. So Kim is a road warrior, and she is doing battle on behalf of a client right now. But the questions as they come up, we'll be looking at those questions. And so please feel free to type them in the Q&A part of the chat. So Maria, can you post the last poll? There we go. So we have 60% are quality, patient safety, 30% are regulatory compliance, and we do have a clinical informaticist with us. Well, so welcome. So let's talk about this. Just as a context, guys, we're talking about compliance, but we're really talking about safety, patient safety. The vast majority of conditions. So if we look at CMS, which causes the most heartburn, a little bit different with the accreditors, but with CMS, the state agency comes out, and the vast majority of adverse findings are due to medical errors. They tend to be cited either in patients' rights or nursing, and that's the vast majority. These are almost all these conditional findings have to do with one or more errors of some kind, and that's not even including EMTALA, which is almost always driven by some error that happened in the ED. And keep in context that CMS is actually insisting that states get back out now that the pandemic's over and start enforcing things. And we're seeing that. We're seeing regulators at the doorsteps of our hospitals all the time. And this is our belief. So if we're worried about compliance with CMS and the state agency in particular, but even when it comes to Joint Commission things, because what we do in the name of the Joint Commission has to make sense, and that's really to create a safe service. But it not only has to be safe, it has to be efficient and high quality to be sustained. I mean, think about it. If we're doing something in the name of U.S. News and World Report scorecard, we're looking for our satisfaction score going up or our HAPUs going down, and we're doing that. But in putting something in place, we not paying attention to safety or efficiency. It's not going to last. The same thing happens too if we're doing something in safety. I mean, I don't know how many times we look at a root cause analysis and there's some unrealistic countermeasure that's been planned for the root cause analysis. It's not efficient. It doesn't promote patient satisfaction, quality metrics. It's not going to last. I mean, it will last only as long as people are looking at it. And of course, if it's not efficient, same thing, it's not going to last. So somehow we need to get that. Some survey findings, or our, not even the findings, but our response to the findings, don't do any of those things. They don't promote safety. They don't promote quality. They're not efficient at all. And so they won't last. Once you turn your head, those solutions just go away. So the name of the game is to balance quality, safety, and efficiency with everything we do. So just think about this. The last time you were involved with a state survey agency, what are the 4 elements that you probably put on your plan of correction? And what were those elements? Well, we'd probably discipline the caregiver. It was a medical error. So of course we're going to discipline people. We added a page or policy, or maybe even created a new policy. We added something to the electronic record to better capture things. So mainly so that we could monitor the documentation because of the bandwidth it would take to do it any other way. And so we could monitor documentation or approve the surveyor. We just added to that documentation burden. Name 4 things that don't do a thing to enhance patient safety. Discipline the caregiver, add a page to the policy, add documentation elements, and monitor retrospectively. Does nothing for patient safety, really. And this is becoming more important than ever because, you know, a third of healthcare workers, a third of nurses have left the field, 1 in 5 healthcare workers, even higher representation of nurses. So the folks that are at the bedside are new grads or travelers. They're folks that are in and out, and almost a third of all nurses have just left the profession during the pandemic. And it's had an impact on the quality and safety. We all know that. And we see it in ED overcrowding of our hospital admissions, which is what backs up into ED. We don't have enough staff upstairs. We have too many patients. People wait in the ED, and there's really good documentation out there about the impact of that overcrowding. So what I'm going to do here for the remainder of the time is get into some practical tips here. Practical tips really for decreasing the burden of unrealistic expectations as reflected in the medical record and otherwise. So how do we get to this notion of less is more? Well, I mean, why should you even believe us? You know, I mean, this may sound good, but what do we know? Well, I'll just tell you about my own personal story and how I came to believe this. I was a regulator. I spent 15 years as a regulator, and at the end of that time, I was over all state agency actions on behalf of CMS in Los Angeles County. And I will tell you that even back then, when it was a paper record, because this was many years ago, I'm old, guys, and even then, the medical record did not tell the story of the patient. It needed to tell the story of the patient, but the more we added things onto that, it didn't tell the story. And as a surveyor, as a regulator, I couldn't stand that. I would much rather have a shorter medical record that told the story of the patient. And as we've gone through the years, regulators, and I still deal with the Joint Commission all the time. We have very good relationships. We meet with them quarterly, and they are not at all pleased with all the documentation that's non-contributory to patient care. They get blamed for so much of the documentation, and they're working with Epic and others to back off of that. The state regulators are, you know, our approach is less is more, as you will find out. And the regulators love it. In fact, some states, when they do a directed plan of correction, in other words, where the state is, the institution can't bring itself into compliance, they will say, well, you need to hire Chartis to come in and help you get in compliance, and we will authorize them as a compliance monitor. So the state agencies like our approach that less is more. It's more term, and then CMS has these systems improvement agreements. The last time we spoke at a CMS conference, which we do periodically, there had been a total of 14 systems improvement agreements for hospitals of one kind or another across the country. We were selected for 7 of those SIAs, and all the rest were one-offs. This company did that one, that company did the other one. We are by far the most experienced in these SIAs, and the system improvement agreements are, the hospital is critical to the community, but can't seem to find its way to compliance. And all of these things led us to less is more. And I have another story I can tell you about that. But let's talk about triage a little bit. This was a question that came from one of our membership clients. And they said, hey, Bud, we're having difficulty getting patients into the ED because triage is taking so long. And I'm wondering what is really required, or what do you suggest is appropriate for the triage nurse to be asking, not what's asked throughout the stay, but just the triage nurse, so we can get people in the back. And so this is the list of what the client currently had. So travel, screening, and vaccination at that time, that probably made sense. It no longer is. It may or may not make sense depending on what your situation is right now. We understand that, but that's short-lived. The core of triage is going to be a brief note about the patient's presenting complaint, their vital signs, and then really the ESI level is what you want, because triage is not the full assessment. It's just saying who goes first, second, and third. That's all triage is. And so when you get into airway, breathing, circulation, disability, those are things that will be assessed throughout the stay. Obviously, if they're having difficulty breathing, their ESI level is going to be a level 2, and they need to be seen within 15 minutes. But you don't have to separately document that. That goes into the decision-making process of the nurse for the ESI level. Stroke screening, we want to do that, but again, that's incorporated in the ESI level. We don't need that separate we shouldn't need that separate scope tool. Now, we do realize that maybe triage nurses aren't experienced as they used to be, but having them document more is not going to get them to thinking better. We've learned this over and over. It just doesn't work. That's not theory. That's the reality. Having them document more does not make them better critical thinkers. Is there severe sepsis? Again, we've got the ESI level. If they have signs and symptoms that would lead us to believe that, then let's get into the back. Suicide screen. Now, a lot of places screen everybody for suicide, and folks believe for some reason that that's required. And other folks know that it's not required, but they still want to do it because they want to catch everything. Well, it really drives in our suicide webinar that we told you about is posted. If you have a question about that, attend that webinar. We will show you that it really has a lot of false positives. If they're behavioral health complaint, absolutely you have to do a suicide screen. If not, then you don't have to do the scale. You're always looking for things like abuse, neglect, and suicide as part of your ongoing interactions with the patient. But as far as a suicide screening scale, like the Columbia scale, that's really only required for behavioral health, the primary behavioral health issues, not secondary. They're homeless. The falls risk scale. Let me go back to that. Falls risk scales, the patient's falls risk will change if they're put on a gurney, if they've got an IV in, if they're given a medication, it changes dynamically. The ED is really truly an ambulatory setting. Once they become an inpatient, those scales have a little bit more impact, but as we know, we're all struggling with falls across the country anyway. And the scales are important, but they really not at triage. That's not to say that if somebody has difficulty ambulating that we don't help them ambulate, ask if they want a wheelchair. That's natural, but that's not part of triage documentation. So suicide screen for behavioral only, homelessness, domestic violence. Again, that's something that's not, a lot of people think, well, I have to check for abuse and neglect. And so let me check that off the list and I'll just do it at triage. Well, that doesn't work that way. The impression about abuse and neglect is something that happens throughout the stay. And if you say there's no signs of abuse and neglect now, and you document that, you don't really know. I mean, if somebody comes in and they've been beat up by their spouse, okay, that's pretty obvious that that's going on. But the assessment for abuse and neglect, there's a lot of factors that you need to follow, and putting that screen in your triage note does not help you. Obviously, you're going to check for weapons, belts, and shoestrings, but documenting that you've done that at triage doesn't actually do that function. So it turns out that the client, we encourage them to restore the emphasis on triaging the patient and free up medical resources and get the people back sooner that need to be back so that you can actually give good care to the patient. So that's sort of a high level understanding of what's bringing us here. But let me, I'm going to play a video here, and you guys can be asking your questions as we go along, from one of our senior consultants, Kim Wilson. She's got 20 years experience as a nurse and in leadership roles. And she's an informaticist, and in addition to being very skilled in critical care, and really has the most experience that I know of anybody who comes in the name of compliance in particular, and helps people actually take a lot of excess documentation out of the nursing notes so that actually the story of the patient comes out. You can communicate better with the rest of the care team. You're not tripping yourself. You're giving people more time to actually care for the patient, and you're exposing critical thinking or the lack thereof in the method that she's going to be talking about. Bottom line is that the nurse gets to spend a little bit more time with the patient. So it's a win-win-win-win-win. And even though you're going to be hearing her talk a lot about regulators and surveyors, trust me that the regulators love this approach. We have never had a single regulatory agency say, no, your approach to simplifying this medical record is not working for us. It works 100% of the time. So with that, I'm going to introduce Kim, and we'll let that go. And as you have questions, please put them in the Q&A. Whoops. Excuse me. All right, here we go.
Everyone, my name is Kim Wilson. Today, I'm going to talk to you. Hi, everyone. My name is Kim Wilson. Today, I'm going to talk to you about doing more with less in your policy and EMR documentation. As an informatics nurse, one of the things that I get called into hospitals a lot for is to help simplify EMRs. There's complaints from nursing staff and providers and executive leadership that staff are spending more time at their computers than they are at the bedside. And that can be a problem for your organization for a lot of different reasons. So I'm going to help walk you through a couple of the myths that I see happen a lot of the tips and tricks that I use when I go into organizations to help them simplify their medical record, and talk about a lot of the regulatory smoke and mirrors that happen out there. So we're going to walk through understanding documentation requirements, interpreting the regulatory requirements, how to use your EMR to work smarter, not harder, and some simple policy changes that can have big clinical impacts. First, we're going to talk about understanding documentation requirements. There's a big difference between the words assessment and documentation, but we often see these words used interchangeably in policy and practice. People think just because we say you have to assess the patient, that you absolutely have to document that. And I know there's that myth out there that if it's not documented, it wasn't done. And that's absolutely true in a lot of cases. However, there's some instances where that's just not feasible. So one of the biggest problems that I see when I go into an organization are these overly restrictive policies that will say that in an ICU, a head-to-toe assessment has to be completed and documented every 2 hours. Well, absolutely, the assessment needs to happen. There's no requirement for that to be documented every 2 hours. And that's extremely burdensome for a nurse to have to document a full head-to-toe assessment every 2 hours. So instead, we suggest that the assessment occur throughout the shift on an ongoing basis, and only the deviations from the original assessment be documented. That way, you're still assessing the patient constantly throughout your shift. However, the only time you're going to see the documentation is on initial documentation, and then subsequently, if there's any deviations from that original assessment. It's understood that there's no change in the patient per policy unless you see me notated in the record. And that can decrease a significant amount of documentation burden. The patient's still being assessed, which is what the requirement is, but the documentation only happens when there's a change in care from that original assessment. And that can make a significant impact for your bedside staff. And you can do that on a lot of different types of units. I've seen in telemetry floors where they require 24-hour documentation. Again, have it to where they document beginning of shift and then only document to the deviations in care throughout the remainder of the shift. And that will make a significant impact. You really need to understand the requirements as well. For CMS and Drug Commission, they're almost silent on the fact that they're definitely silent on how frequently you need document per shift, but they don't tell you what actually needs to be in the assessment. So there's requirements that says an admission assessment has to occur, but no one tells you anywhere what has to be in that admission assessment. There's only about 5 different things that actually ever mentions in the COPs anywhere about things that should be captured on admission. Yet we walk into hospitals and we'll see these 300 questionnaires on admission to a unit, and 90% of that documentation is absolutely just not required. And it's something that the hospital has required per policy instead. So you really need to understand that whatever you put in policy, you're held to during survey. So really understand what the requirements are before we write our policies to require documentation that truly just isn't required. And that will make a significant impact. We can typically reduce the nursing admission assessment by usually 60% right off the bat, just because most of those questions that when I go into a hospital, when I look at Epic and Cerner, MedHost, Allscripts, those questions are just not required from a regulatory standpoint. So you really can go in and determine what's policy driven and what's regulatory driven and call some of those questions back. And that again would reduce a significant amount of burden on your nursing staff. The next thing we're going to discuss is interpreting regulatory requirements. So how do you prove that an intervention actually occurred if you don't document it? Well, there's lots of ways that you can do this. And so this is where we're going to ask you to start thinking outside the box. Often surveyors will come into the building and ask you to document something that's absolutely just not a requirement. So this is where we'll ask for you to go back and actually look at the regulation and make sure before you have that knee-jerk reaction to add that to policy and to the EMR. So we've seen this be one of the biggest causes of having these overly inflated EMR systems. When we go in and I'll see a question within the EMR and I ask, why are you documenting that? I'm not clear where that's coming from. I often hear, well, Joint Commission wants that, or CMS asks us to do that, when there's actually no regulatory requirement out there anywhere. Instead, it's usually a surveyor proclivity. It's a pet rock for them. It's something that they feel like that should be documented. They consider that best practice, and that's how they want you to do it. But they can't cite you for wanting you to do something. They can cite you for the regulations. So you can do one of two things. You can just shake your head and agree with them and say, that's a really great point, and I'm going to go back and look that up. And don't make any knee-jerk reactions and start calling your informatics team to have this built in the EMR or make policy changes. Go back and actually read the regs and better understand that. And secondly, you can question the surveyor politely and say, that's a really great point, and I would love for you to be able to show me where that is in the regulations, because as many times as I've read them, I've just never been able to find. And often that's when they'll back down and tell you, well, it's not really a requirement, but it's best practice. So again, really understand those requirements. And if you're not comfortable with that, call someone on your regulatory team and get some advice from them before we start making these knee-jerk reactions, because that's one of the biggest reasons that we see these overly built EMR systems right now. You really need to eliminate redundancy. Often I go into a hospital and I'll see the same thing documented 3 or 4 different times by 3 or 4 different disciplines. There's no need for that document, and that actually can create a burden for you from a regulatory standpoint. If we have the same person or the same information documented by 3 or 4 different people, there could be inconsistencies in that documentation or contradictory information being gathered by those people, which can make you vulnerable. So you want to make sure that you find the subject matter expert who should be actually gathering that information and have that captured 1 time in the record instead of 4 times in the record. There's things too that we see documented very frequently that really just should not either be in the record or be captured in a different method. So one of those is hourly rounding. Hourly rounding has been, there was a surge of this many years ago where everybody wanted to prove that someone went into the patient's room for various reasons. And so the idea came about that we would just force staff to document hourly rounding, and that would prove that they were actually in the room. Same thing with safety checks. If we force people to document it, then surely it happened. I tell people all the time, you will never force compliance through the computer system. It's just not going to happen, because to document that hourly rounding, they have to be at a computer, and 90% of the time that computer is not even in the patient's room. So you're removing people from the actual practice that you're asking them to perform. So instead of having them document hourly rounding, there's way more options to actually ensure that staff are rounding on patients, such as administrator rounding, going around and talking to the patient and asking them, has anyone been in your room lately? Is your pain being managed? There's lots of ways to do this. I mean, you can see where meds were given and vital signs have been, taken. Wound management is occurring. There's lots of ways to prove that people are rounding on patients rather than forcing them and removing them from the patient and forcing them to a computer every single hour to document hourly rounding and safety checks. So these are some of the things that we actually ask you to start thinking outside the box on how can you really capture that without pulling staff away from the actual intervention that you're trying to make happen. Patient education, care plan interventions, those are things that we see typically documented, duplicate, triplicate all through the medical record. Patient education is documented in the admission assessment. It's in the patient education tab. It's in a flow sheet somewhere. It's on a pamphlet that we gave the patient. There's so much redundancy with patient education. It's all over the place. So instead of having it, peppered all throughout the record, where's the one true source of information for that? Where can we document that it maybe it interfaces to different parts of the record so that we don't have to have staff go into 4 and 5 different places to document patient education. So again, thinking outside the box, how can we help reduce that burden of staff documenting the same thing over and over and over? Care plan interventions, we've seen a big movement here recently where people will take those care plan interventions and move them into their flow sheets into their assessments, which is great. I love them being there. But then staff would then also have to go back over to their care plan and document them a second time. If you're going to move them into one area, then why keep them in a second place, so that we're just creating a redundant process? And again, if those two things don't match, then that just starts raising eyebrows for surveyors. So really try to keep your interventions located in one place and figure out what's best for you. If it's in your flow sheets, then keep it in the flow sheets. But asking staff to document the same information twice is just so burdensome, and it's just duplicative. We don't want to waste our nurses' time documenting the same interventions over and over and over. With pain assessments, you absolutely have to assess the patient and reassess the patient. But again, what that reassessment looks like and how soon it has to happen after the intervention is what typically gets hospitals in trouble. We will see policies that say pain reassessments must occur within 15 minutes or 30 minutes after the fact and be documented concurrently. That second part is what gets you in trouble. We go into hospitals all the time. Clearly, patients' reassessment was done, the patient is sleeping, or the intervention was effective, but they missed that reassessment by 30 minutes or an hour of documenting it. And you get cited for that. So that's one of the easiest things for a surveyor to cite you for, is your pain reassessments, because they're not documented concurrently, which is what your policy requirement is. So there's some easy things you can do in policy to ease that burden by saying, the pain reassessment will occur at a specified time, but the reassessment can be documented within the shift, or a specified time that's not so stringent that you're going to get cited every single time a surveyor walks in the building for your pain assessments. And that's typically what we see happen. So really start thinking outside the box about ways that you can capture documentation without having that redundancy and having it be so strict in policy that there's no possible way that you're ever going to be compliant. We'll talk about how you can use your EMR now to work smarter, not harder, because I am all about that. So one of the things that you can do, and that I often do when I go into an organization, is do an inventory of your clicks and questions. So I'll typically go through an admission assessment or shift assessment and look for all the questions, do an inventory of them, and cross-reference those to other areas of the hospital. So your ER assessment, to your inpatient admission assessment, to your L&D questions, to your flow sheet questions, and try to figure out how many times are we actually asking the same question over and over and over? And where does it really belong, and where does it live? And how can I get rid of some of these questions that just don't matter to the bedside nurse, and it's not driving care in our hospital? So that's one of the first things that you can do to help reduce some of the burden, is to go through and inventory your questions. You also need to look at needs versus wants in your admission assessment. There's a lot of questions that we need to ask, but there's a lot of questions that we just want to ask. So there's a huge difference between those. And again, there's no regulatory body anywhere out there that tells you the contents of the admission assessment. That's whatever your policy and your EMR dictates. So that admission assessment can be small, or it can be very large. And typically when we go into organizations, there's an extremely robust admission assessment that often takes people up to an hour to complete. So the admission assessment, you can get the most bang for your buck by reducing the documentation requirements, because again, probably 60%, 70% of the questions that you're asking without me even looking at your EMR are probably not required. So the problem that we see is how these things get like this is usually the kitchen sink methodology, right? We just throw everything in the sink because we think that we're scared that if we don't ask that question, we're going to get in trouble. So everybody just throws it all in there. And what you end up with is this 300, 400 question admission assessment that is just so redundant and overly built that staff skip over half the questions. We also build out these big, bad admission assessment because nurses are at the bedside 24/7. because they're there, it makes more sense for them to ask the question, is typically what we hear. But you have to ask yourself, where do we draw the line with what nursing is required to do versus other disciplines? So it's okay for nurses to screen patients, and they should be screening patients. We should be doing a nutrition screen on every patient when they come into the hospital, but that doesn't have to be 20 questions. It can be 3 questions. And then they screen out and then consult nutrition based on a set of criteria. That doesn't mean that the nurses then go in and do this robust nutritional assessment. That's where the subject matter experts come do. And that goes with everyone else, case managers, social service. I'll often see nurses doing this massive case management, social worker assessment that talks about all their prior living conditions and what equipment they're using at home, and all these just significant amount of questions that truly is not relevant on an admission assessment in acute care setting. That's where you get those other disciplines to come in and ask those questions. So you really need to figure out who should be collecting that information, and should nurses be collecting data for other disciplines? Again, figure out, where do you draw the line there, and what should nurses be doing versus other people in the hospital? From an ED and inpatient flow perspective, any nurse in the hospital that has gotten a patient from an ER has heard this statement: they just asked me that in the ER. Why can't you people figure this out? Why can't your computer systems talk to each other? People get tired of answering the same questions, just like nurses get tired of asking those same questions over and over and over. Patients get tired of answering those same questions too, and they have to question the sanity of an organization that was going to ask those same questions over and over, and have our computer systems not be able to talk to each other, or there's no communication between staff members, right? So the physician comes in and asks all these questions that the nurse just asked all these questions. And that's very frustrating for a patient, and it's frustrating for staff too. When we hear they just asked me this in the ER, because that's my first question too, is, well, then why am I having to ask this question again? So there's really the computer systems out there today, the EMRs, they really, most of them have the technology to be able to talk from their ER system to the inpatient system. They're integrated. So there's really no reason that we should be asking these same questions over and over. So that goes back to the very first thing on the slide: inventory your clicks and questions. If those questions are being asked in an ER setting, then we should not have to ask those questions again when they're admitted to the floor. Now we're going to talk about some simple policy tips that can help you weed out some of the noise. So one of the biggest drivers for noncompliance with documentation is policies. It's actually not the EMR, it's your policies. So policies are supposed to drive care in the hospital and be a pathway for staff to be able to understand expectations. So when a policy is over prescriptive and we've overinterpreted the regulatory requirements, we've built in these documentation expectations that are just unreasonable, then that's when everything starts falling apart on the back end. So there's a lot of things that you can do up front in policy to help on the back end for documentation. So I'm going to walk you through some of these policy tips on the next couple of slides. So we're going to talk about, regulation myth, like we talked about, the last surveyor said that we had to do that, or pet rocks, the kitchen sink methodology. Well, while we're at it, let's throw this in the medical record. Thinking that if we require it in policy, it will drive practice, which is just not true. And believing more in our policies will save us from a lawsuit, which is absolutely not the case. When there's no path from expectation to operational reality, and not aligning our policy, practice, and the EMR. So we're going to walk through these tips now. The first thing that I recommend is to ask questions. Whenever you're writing policies, you really need to sit down and think about what you're doing and whether or not this is actually policy worthy. Most of the documents that I review that I'm sent about documentation really is just education, or it's a competency. It's not really a policy. So understanding the difference between a policy, a guideline, a procedure, that's really important when you're going to sit down and start developing policies, so that you understand whether or not you're really writing a policy versus maybe just guideline or education for staff. Just how I said earlier, inventorying your EMR, you also need to inventory your policies. I cannot tell you how many times I've gone into a hospital and I've asked for sedation policies, and I've got 5 moderate sedation policies that are contradictory. They don't align with each other. They've been written by different people throughout the organization for different departments. Having different policies for the same type of procedure is extremely dangerous for you, because you set a precedence for having different standards on different units. So if monitoring of those patients who are receiving moderate sedation or any type of sedation should be the same no matter what area of the hospital you're in. So you really want to make sure that you're inventorying your policy and utilizing what you already have out there if you're going to be creating a new policy. Also ask yourself the question, does this meet the intent of the regulation? Is this even a requirement? So go back and look. Remember, it's okay to question whether or not this is actually a regulatory requirement, and understand what does the actual regulation require. And then are we putting cherries on top of that? So here's that kitchen sink methodology. Just because we're going to add the one thing that's required doesn't mean we need to start adding more things to it. So just keep it simple and keep it to what the requirements are. And you're going to likely end up with a policy that matches practice at the end of the day, because when we start adding extra things on it that are not regulatory requirements, that's just something that somebody wants, that's how we end up with these overly architected EMR systems that just don't make sense, and you don't have good compliance with that, and you have staff that are back to the beginning that are extremely frustrated because they have all these documentation requirements and it doesn't make sense to them. So just make sure that you're not adding cherries on top of the regulations that already exist. A few more of the questions is, who is my audience? So this one for me is a big one, because I see a lot of people who write policies, and they write policies more for themselves or for their department than for the actual people who are going to be implementing the actions. So for example, if you're writing a wound care policy, you need to make sure that that wound care policy is intended for the staff at the bedside who are actually trying to perform those wound care interventions, or for the providers, not for the wound care team. These policies need to be in words that your audience understand. The workflow needs to make sense for the bedside staff, not for the wound care team. You have to ask yourself questions like, is this something that can actually be operationalized? Does this make sense to the people who are going to be actually performing these interventions? Does policy match practice? Have you asked your audience for input? Have you gone out to the bedside, spoke with the nurses and said, hey, here's what my proposal is for policy. Does this make sense? Does this match your natural workflow? And if the answer is no, then you probably need to go back and try to write your policy again for your audience and not for your department. One of the other questions you need to ask is, are you setting people up for failure? Are you asking them to do something that can't possibly be sustained? And we see that happen a lot. We'll put something in policy like every patient on this floor has to have a pulse ox. Well, if you don't have the pulse ox machines, then you can't possibly sustain that practice. So don't put things in policy that can't possibly be sustained in reality. If it contradicts our natural workflow, as a nurse, I can tell you, we are the worst at getting things done. We are just going to get things done and make sure our patients are taken care of. So if you're going to tell me to do something that contradicts my natural workflow, I'm likely not going to do it. If it just doesn't make sense to me, if it doesn't go along with the natural flow of how I do things every day, then I'm probably not going to do it. So again, that's why you need to understand your audience and ask for their input when you're writing these policies, because you don't want to set people up for failure by requiring something that just completely contradicts their natural workflow. And again, we talked about this, adding additional requirements for best practice. Best practice is wonderful. We can teach best practice all day long, but it doesn't mean it has to go in policy. We teach expectation and put in policy what the actual requirements are. So we don't want to do anything else that's going to require unnecessary documentation. So that's like the hourly rounding. Absolutely in policy say that you should be hourly rounding on your patient. But adding the documentation requirement for that is setting people up for failure, because they're going to miss one inadvertently. It's going to happen, and you're going to be cited for your policy, not for a regulatory requirement. So again, be careful. Ask make sure you know your audience, and don't set people up for failure by writing something in policy that can't possibly happen. Okay, now we're going to talk about the don't do it's. So one of the things is you never need to do is develop unrealistic expectations, because these are never sustainable. I see this happen a lot when there's an adverse event in a hospital. Everyone immediately goes into fix-it mode, and sometimes some irrational thoughts occur as a result of that. There may be a pending lawsuit, or this is being public in the newspapers, and so we feel like we have to be overly zealous with our interventions or our fixes here. So we develop something that's absolutely unrealistic and non-sustainable. So for example, if you had a patient fall with significant injury, right? Then our immediate knee-jerk reaction would be, oh, well, we need to do every 2 hour, we're going to do fall reassessments on every patient in the hospital every 2 hours to make sure that we're catching everybody who's at fall risk. Well, that's not realistic, that's not sustainable, and that's not going to fix your underlying problem. So you need to think about truly what the problem is, get to the root cause of it, and develop policies for sustainable improvements in your organization instead of developing unrealistic expectations. And then don't ask people to document something just to prove they did it. I can't tell you how many times I have been asked as an informatics nurse to build something because we didn't feel like staff were actually performing an intervention. So we need something to prove that they did it. There's lots of ways, as we discussed earlier, to think outside the box. How do you determine compliance with a practice without forcing documentation? Because again, forcing documentation will not force the actual intervention to happen. You just have someone potentially pencil whipping an intervention in a computer system without actually performing the event. Because the more we require them to document, the more we remove them from the patient. So think outside the box on how we can prove things happened without forcing documentation. And again, don't develop policies that conflict with other existing policies. We talked about this earlier. Inventory your policy is the best thing to do before you sit down and even try to draft one, just to make sure that this doesn't already exist out there. Okay, and the last point is don't make a policy change for surveyor preference. Just because a surveyor said they want you to do something, again, doesn't mean that it's right. In the name of best practice, again, we teach best practice and we put the actual regulatory requirements in our policy. You should not have policies that are 20 and 30 pages long. Typically when I go into a hospital and I see a 15-page restraint policy, I know that I have a problem with restraints before I even look at the practice. Because when your policies are that big, staff are not reading them. So keep your policies extremely simple and to the point so that staff actually read them and can follow them. And again, write them for the person, the intended person who's going to be operationalizing those policies, and not for a surveyor. Don't make a policy change for legal concerns. A policy will not save you in a court when care has been substandard. You failed the patient, period. A policy change is not going to make that change. So you just need to remember, you need to truly get to the root cause of your problems before you try to put something in policy to knee-jerk reactions. Again, like with the example with the patient who fell, you don't want to go for legal purposes and say, every 2 hours, we're going to do a fall assessment on this patient, on every patient in the hospital, because you think that's somehow going to save you in court, because that's not going to. You're actually making a worse problem for your nursing staff and your patients by asking them to do something that's absolutely not sustainable. Don't make a policy change because you think policy dictates practice. I don't know how many times I can say this. You will never succeed in forcing compliance through policy and documentation. You must understand the process. You can say in policy all day long that this is what's going to happen, but unless staff actually understand the policy and follow it, then you're not going to have compliance. So ultimately, policy should match practice. Practice should match policy. And if that doesn't happen, then there's going to be a vulnerability during survey and probably a vulnerability for your patients in the hospital. So these were some quick policy tips that and EMR tips that you can use in your hospital. Hopefully this was helpful. And that is it, folks.
Thanks, Kim. So in absentia, I want to say, one of the points she was making is that documentation doesn't drive practice. It's just so by eliminating excess documentation, you can actually reinforce the documentation you do need to communicate the patient's condition. But then that leaves open, well, how do we then change practice at the bedside? And there'll be a webinar coming up soon. I think it's either going to be in March or April, where we get into a lot of detail as to how real-time change management happens and how we really use a tool that we call care facilitation to make changes quickly and make sure that the things that are happening that aren't measurable in the medical record or accurately measurable in the medical record can be done. But I'll give you a little clue. One of the reasons we create the documentation is because we just don't have the bandwidth or the process to go out and look at concurrent practice. But stay tuned. Please come back to our website and look for upcoming on what we call care facilitation or changing practice at the bedside and while avoiding excess documentation. So I have, is there a place where we can find a summary of documentation requirements for acute care hospitals? Percy is asking. It's a little bit misleading. The documentation, the little circle D that the Joint Commission puts in their findings, you can look at those, but that's really for documentation of policy, not clinical documentation. And so I don't know that we have an overall inventory of elements that are required, but we do in our policies, we have model policies around everything that is required. And so if you want to contact us, we can put you into contact. This is what you would need to document for assessment and reassessment. For example, just in general, this is what you would need to document for the care plan. This is what you would need to document for suicide. This is what you need to document and in the assessment reassessment policy. So we do have those sorts of things. So Percy and others, if you're interested in following up on that, just that you'll be receiving a questionnaire, post, what else can we talk about in the future? And perhaps this could be the subject of one of our future webinars. But in the meantime, maybe we can supply you with our model policy. Again, policy and documentation have to be like this, that those sorts of things we can at least talk about. As Kim said, the biggest overkill is on the assessment. It can take up to an hour. So there'll be a way to contact us after this, Percy, and anybody else who's interested in that. I want to thank everybody for attending today, and I'm going to give it over to Maria to close the conference.
Fantastic. That is.
Oh, by the way, Karen Simpson, yeah, the recording will be posted on our website so it will be shared on our website, and it should be up by next week, if not sooner.
Yeah, fantastic. That's all the time that we have for today. I want to thank Kim Wilson and Bud Pate and all of you for a lively and informative discussion of this important subject. As we mentioned, the Chartis Clinical Quality Solutions team will follow up with a response to any questions we did not get to during today's Q&A. To learn more about the content presented today, please fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.